Everyone, it is May 7th, Wednesday, House Healthcare, and we are still working on markup on S-126. So, Jen, and you're ready, if you want to put up the language where we left off.
Yes. Good morning, Jen Harvey from the Office of Legislative Counsel. Let me just get us to where we left off a minute.
And we're on version 1.3, right?
We are still looking at version 1.3. Yes. Do you have a version that makes all the changes from what you talked about yesterday? But I think it makes sense to keep going through finishing your markup here. So let me stuff. This put up language.
And we're gonna post the changes you made. I don't know if it's gonna be 1.4 or 2.0 or what.
2.1.
2.1. Never quite sure when it goes from a new number to another.
Yes. Loosely, it gets a new number in the front of the decimal point after you've seen a draft. I'm bringing a new draft to the committee. The numbers after the decimal point are usually when I'm sort of working with people offline and making changes. But occasionally, if I'm just making small changes, I change the number after the decimal point. So it doesn't necessarily.
It'll be posted, but for those following along at home, we're on draft number 1.3.
Yes. Okay, so here we are at section 12. Retaining, page 44. Retaining accountable care organization capabilities. And in this section, I just took out the references in the section heading to the Green Mountain Care Board and the blueprint that was based on an earlier version. I don't think it specifically needs to say Agency of Human Services. So it'll just say retaining accountable care organization capabilities, report, and directing AHS to explore those opportunities. Otherwise, no changes in that section. Then we get to the reports, the implementation updates and reports. So you deleted the first one-time report here from the Agency of Human Services. You put some more things into their ongoing reporting, and you have them doing some reporting on shorter term efforts throughout the fall. So the next section here is section 14. This is the Green Mountain Care Board first report on implementation. And so this has still on or before February 15th, the board providing an update to this committee and Senate Health and Welfare on the board's implementation of this act, including the status of its efforts to establish methodologies for and begin implementation of reference-based pricing, took out the reference to development of global hospital budgets, and the effects of these efforts and activities on, and then increasing access to care, improving the quality of care, and reducing the cost of care in Vermont. And then here's where the global hospital budgets, hospital global budgets, I feel like we use both terms. It was global hospital budgets here. So the board shall also report on the potential future use of global hospital budgets, including providing the board's definition of the term global hospital budgets, determining whether it is feasible to develop and implement global hospital budgets for Vermont hospitals, and if so, over what time period, and the advantages and disadvantages of pursuing global hospital budgets. So that would be the February 2016 report. That's there.
And if at that point we recognize or we decide that it's something that we should pursue, then we can create legislation to tell them to do that.
Exactly. All right, then we have section 15, and this is the ongoing reporting for the Agency of Human Services. And this is in Title 3. So it's not a title we're in a lot, but this is the title on the executive branch, and this is in the chapter on the Agency of Human Services. And in existing law, this is where the Director of Healthcare Reform position sort of exists. And so I added it in here since it's about healthcare system reform and improving quality and affordability. So it still has on or before February 15th annually, the Agency of Human Services providing an update to this committee and the Senate Health and Welfare Committee regarding the status of its efforts to develop, and the language I've been trying to use now throughout is develop, update, and implement the statewide healthcare delivery strategic plan. taking out the reference to advancing healthcare data integration, because now it is just a report coming back to you, and you're not telling them to do anything. And coordinate hospital transformation activities. You've got that separate reporting happening on that area. So now I have instead, and on the activities for the Healthcare Delivery Advisory Committee, and the efforts of these efforts and activities on, and then using that same language as for the board above, increasing access to care, improving the quality of care, and reducing the cost of care in Vermont.
So again, we're just asking them to keep us up to date on how it's going.
Yep, with developing, updating, and implementing the strategic plan, and the activities, what the Healthcare Delivery Advisory Committee is doing, and what the effects of those efforts and activities are on care quality and cost for access quality. Section 16 is the Green Mountain Care Board annual report. Their annual report is due by January 15th, and this is adding to the board's annual report requirements. So the status of its efforts to establish methodologies for and begin implementation of reference-based pricing. So that's in that one-time report and ongoing. And any considerations regarding the future use of global hospital budgets and the effects of these efforts based on same things: increasing access to care, improving quality of care, and reducing cost of care.
All right.
We want to add in here a little bit more specificity about improving the quality of care and mirror some of the quality language that we have elsewhere, so that we're like using words like metrics, like improving quality of care to mean everything. I want to see some numbers.
I'm just thinking, I hear you. But I'm thinking that because we have in other parts of the bill that they're using metrics, that in their report around quality of care, they're going to use evidence-based metrics that we've legislated in other sections.
Why not refer to it here as well? We want to see, their work.
Jen, do you know where we have?
Yeah, I'm trying to think of how, so this is the annual report is going to talk about the status of their efforts to do reference-based pricing and any consideration of global hospital budgets. And the effects of those efforts and activities on kind of access, quality, and cost. So I'm trying to think of that maybe.
Yeah, I'm just thinking if we've told them to develop metrics to measure this stuff, all we're telling them here is in your annual report.
I'm not sure. I think a lot of the language about developing quality metrics was in the plan.
Yeah, that's in the plan.
Strategic plan.
Leslie.
A comment that they're a big shop and they do this work as they're sort of embedded in the quality world. So I think
This is the Green Mountain Care Board.
that's right. I think they know a lot about quality. I mean, I was right. I felt very comfortable saying, we've had testimony from Elena Berube and Dr. Fisher and other people who understand the quality world. And I think that the Green Mountain Care Board really understands the quality world. So I don't know that we need to be specific, but that's my opinion.
Yeah, go ahead.
Board, yesterday I was saying that we have in the Senate right now a quality position. There is no current work. Yeah, they don't. Other than that's currently that, anecdotally, there was actually an article in the Rutland just Monday around the quality in Vermont from Leapfrog. And it didn't report Vermont hospitals really well. But at this moment, the Green Mountain Care Board maybe is aware of some quality, but it's not a part of our work.
I get it.
Testing.
Yeah, I get it. But they know it. They may not. I'm just saying.
I'm not gonna die on this hill. I just
think it would not be a big deal to ask to see any work that they've done on it.
47.
Measurable, 11. If we're gonna change it here, then we're gonna change it in all.
Right, that's what I was gonna
Those
say.
things.
Want to be consistent with the language.
We use the word measurable improvements in quality of care.
Well, you're just having them report on the effects of the efforts on improving the quality of care,
Excuse me, everyone.
unless you want to change that language.
Lisa, do you have thoughts on this?
I share Mari's appreciation and need for looking at the, consistent eye on quality and measurement. But I also think that it is consistent, this language is consistent with the specificity around access and cost of care. I'm comfortable with this for that reason.
Are you okay, Mari? Yep. Okay.
Okay, then we have effective dates. The effective dates are pretty simple. The change to the Green Mountain Care Board annual report, I have taking effect on July 1st of 2026, so that it will apply for the report due in January of 27. And then the remaining sections will take effect on passage. And the reason for the board annual report not taking effect until the 27 report is because you have a specific 26 report you've asked for. That's it.
We didn't,
So now.
no changes.
Yeah, no change.
Cut and paste this into,
So now it's in. I mean, it just has a marker in it that says, here's where we start.
oh, that was a question.
Can you, that last thing, 2026?
Yep.
What was the reasoning behind that?
So in the bill, section 14, you have the Green Mountain Care Board providing an update on its efforts to establish the methodologies and their for reference-based pricing and their impacts, and also reporting on the potential future use of global hospital budget. So that felt like that was capturing that issue for 2026. So this change to their annual report that'll be due the next January 15th will be for the January 15, 2027 report. So you'll be getting the same information from them, but one of them is sort of as a one-time. And then the ongoing inclusion of these two issues, reference-based pricing and global hospital budgets, will be just without the extra, give us your thoughts on global hospital budgets and how you would do them, but more just the update.
So in 26, we get a special report.
Exactly. Special report, in addition to their annual report, and then starting in 27, it'll be baked into their.
But
Right. All right. Do we want to look at,
I'll look at the new draft that incorporated what
draft?
we did yesterday.
that is posted on our website?
It's posted.
one,
2.1. All right, and so for the most part, I took out everything that you had decided to take out and changed everything that was highlighted as new language to just regular non-highlighted language. And a few places I just went ahead when you were going to delete a section and deleted the section so that you could see the renumbering. But hopefully that will be apparent. So in section 1, you just made some minor changes here.
It's on the, posted on the website. Okay, I think we can probably not even whisper. So a clean. A clean copy as far as like without the yellow.
well, I personally.
Yeah.
I would ask the committee how they want to do this. Is this because we're getting ready to vote.
Wait, we are?
Not yet. This is your changes from what you asked me to change yesterday.
We're not
This is
getting
a
ready
new
to vote.
version,
Okay,
and then I will make you a
Weigh
clean
in
copy
on this.
when you vote.
And then when we get ready to vote, that's the. question.
We'll have the final version
This afternoon.
this afternoon. So this incorporates all the changes we made yesterday. And what I want to do is I want to go through the bill. I know this is laborious. I want to go
Less laborious.
less laborious.
Yes, because there's fewer changes.
And I will just say for anyone sitting around the room, if you have concerns, if there's just something that you really, really deeply, I would ask that you please speak up.
Like, this is our last call.
Because this is last call,
Okay.
last call. And that doesn't mean we're gonna make the changes, it's just, this is. If you have suggestions,
And I work in bars, sorry. But
So,
you have to tell people.
let's
that you're
let's
closed,
go
you know,
through.
Or else they don't leave.
That's gonna be stuck in my head. Okay.
No, you didn't.
All right, so we have the purpose section. For the most part, this is the same as what we looked at yesterday. I incorporated the changes we talked about achieving transformation of and structural changes to Vermont's healthcare system. In number 3, in the goals, stabilizing healthcare providers, controlling, and we added the costs of commercial health insurance and struck premiums, and managing hospital costs based on total cost of care, beginning with reference-based pricing, and it's not shown, but I struck and continuing on to global hospital budgets. And then this incorporated the changes in 4 and 5.
Do you want us to weigh in as we go or wait till she runs through the whole thing?
Weigh in as we go.
Because I have a comment about the goals.
Okay,
So I feel like the bill's going in a good direction, but we're still missing something. How do I put it? Like reaching for the highest possible goal. And so I was trying to think, how can you do that with a few words? Because I know we're at the point where we can't like create entire sections. And I thought about this like very late last night. And one particular phrase we could insert somewhere in the goals would be indicating, and maybe the committee doesn't agree with this, and that's fine, but indicating that the ultimate goal is for healthcare to be a public good, however we do it. Like whether it be a hybrid system like we have now between public and private, whether it be people bartering horses again because there's no Medicaid, whether it be, universal healthcare someday. So what I was wondering is if maybe in part 2, we could say something like where it's an integrated system of care with robust care coordination and increased investments, et cetera, as a public good being inserted in there somewhere.
what about, and I'm just throwing this out here, and I can't believe I'm throwing this out here, to add something, but to move us to a system as envisioned in Act 40.
Yes, exactly. That's what I'm getting at. Law right now, and this bill does refer to the principles of Act 48 in multiple places. I flagged them all. So,
Yes, it refers to the principles for healthcare reform,
yeah.
which are also codified.
Mhm.
Yeah, I really appreciate it, but I don't think that's what this bill is about.
And we do reference Act 48. I mean, we already have Act 48.
To be clear, we do not reference Act 48. We reference principles that were codified in statute during Act 48
Okay,
and have been
Yes.
amended since then.
yeah.
The bill itself does not reference Act 48.
I think that an act relating to healthcare payment and delivery system reform, though, is missing something if we're not taking into account that we've never really followed through on these elements of statute. That being said, I said as a public good because it separated us from all the drama of universal health care. And that's the phrase I really like was advocating for. I was excited you were suggesting going further than that. That's what, but I mean, I'd be happy if we could find a way to say that we want to provide access to healthcare as a public good versus like as a product.
I don't know what that means from a legal standpoint.
I don't know
I'm
what that means.
concerned that that creates obligations on the state that I'm not prepared to assess at this moment in time.
Leslie?
Well, I just looked up the definition of public good and it's complex and requires conversation. And we haven't had that. So, I mean, even though I would agree with you that the roads are a public good too, and we've had there's a lot of different ways to look at public good.
Okay. Thank you very much. I appreciate that, Brian. Let's move on.
Section 2 is hospital budgets and payment reform. This section 2, or that this next grouping is section 2 is the Green Mountain Care Board's duties. I added in that reference for reference-based pricing to begin not later than hospital fiscal year 2027. Sort of clear the purpose for that too. I think that is it for that section. Until we get to reference-based pricing. All right, so now we have reference-based pricing, new language. I think I had maybe had a couple. Excuse me here, but let's look. So reframed, and this is now says the board shall establish reference-based prices that represent the maximum amount that hospitals shall accept as payment in full for items provided and goods and services delivered in Vermont. That may still have been highlighted from yesterday. But this is what we talked about. The board may also implement reference-based pricing for services delivered outside a hospital by setting the minimum amounts that shall be paid, payer agnostic, for items provided and services delivered by non-hospital-based healthcare professionals. Does that seem like what people were thinking? And then that gets repeated again in a little more detail in subdivision 5.
Let's remember, they already have this authority to do this anyways.
Yes, but this was the way you were
Spelling it out.
spelling out sort of the concept of the hospitals and maximum amounts and then other providers minimum amounts.
I think that's great. Thank you.
Great. Just make sure I'm pointing out all of the things that we changed. I guess I left this in just to show because we had talked about putting other healthcare professionals in this part with hospitals and instead moved on to this having their own provision. All right, took out the,
Oh, hold on one second. Eli?
I see later the mention of consulting with health insurers, but is this, is the highlighted constrained to only health insurers or?
it is payer agnostic. We are not mentioning payers. The realities of what can be done will come out later. We do carve out specifically Medicaid and Medicare in the hospital in the part we're telling them to go ahead and do.
So this has no effect on Medicare and Medicaid.
I mean, as I understand it, the board cannot.
Yeah.
So that's why it's not specified. So there is consultation in various places. I'm sorry.
Cover.
Is there a reason to use the word minimum amounts?
Yes.
What's
Would you
the,
like to know what that is? Yes, so the construct for the maximum amounts that hospitals accept is to cap hospital prices. The idea of setting the amounts that will be paid for non-hospital based professionals is to, for example, set higher reimbursement amounts that have to be paid for primary care services than other types of services. So to allow for the prioritization of the types of care or the care settings that align with the state's goals. So you wouldn't want to set a maximum amount that those providers could accept because there isn't an issue with those providers setting rates that are too high. It's to encourage payers to pay higher amounts for higher I won't say higher value like the other services aren't valued, but the types that are trying to be prioritized in the delivery system. But without, but trying to also be as broad as possible within the limits of law about which provider or which payer types are included. Yep. Okay, small change here that happened after committee, that's why it's in green. Reference-based prices established pursuant to this section shall be based on a percentage of the Medicare, and now it just will say Medicare reimbursement and not the rate or rate and methodology. This was an agreement between Blue Cross and the Vermont Care Board that this gave the board sufficient flexibility to include methodologies where appropriate and not where not appropriate, and felt comfortable to Blue Cross. And I don't know if
Everybody good with striking rate? You remember we had a conversation around this, and thank you so much to the board and Blue Cross for coming up with the easiest solution of all.
Great. And then, so it's based on a percentage of the Medicare reimbursement for the same or a similar item or service, or on another benchmark as appropriate, provided that if the board establishes, and now we took out initial, establishes prices that are referenced to Medicare, it may opt to update them in the future based on a different rate of growth than Medicare rates. And then we have language, an added language, the board may also reference to and update based on other payment or pricing systems where appropriate. This, again, maximum flexibility for the board. Let me see where else.
You got a question, Brian?
Well,
All right.
there was a sassy click on my keyboard,
Oh, okay.
but good job noticing body language. I kind of went like make it go faster, so.
I did think he's either being sassy or he has a question.
Okay, next changes start in 3. The board shall begin implementing reference-based pricing as soon as practicable, but not later than hospital fiscal year 2027, by establishing the maximum amounts that Vermont hospitals shall accept as payment in full for, and I put back in, items provided and services delivered, provided that this authority shall not apply to items provided or services delivered to patients who are enrolled in Medicaid or Medicare. That,
My concern is the minimum, from earlier.
I understand, we're not there yet. And I think in remaining payer agnostic on that language, it becomes difficult, but I'm happy to put in a carve out if the committee would like. So, all right, so they will, so does this language work for folks?
It works for me. We're carving out, we're being very specific that it doesn't apply to Medicaid or Medicare.
Right, because this is what is happening in the near future.
Can
Okay.
you go back up real quick? Sorry. Yeah, got it.
My concern is that, Eli Hogan, Agency of Human Services. My concern is that this section is only speaking to the maximum amounts. Whereas the other one spoke to both the maximum and the minimum and excluded Medicaid and Medicare. That I think that the previous paragraph also needs to exclude Medicaid and Medicare to cover both the maximum and the minimum. And especially that minimum, like we would be very concerned that may affect Medicaid and may affect the 1115 waiver. So we have to
Can I
be
ask though,
very
does the board have the authority to set rates for Medicaid?
No, but if it was a minimum amount and didn't exclude, if it was a minimum amount charged by all providers,
No,
then that,
paid to. So it's a minimum amount that could be paid to, but the board doesn't have the authority over Medicaid or Medicare.
I can put it in here, it's not.
If it will, yes.
Yeah.
It shall not apply to Medicaid or Medicare.
our concern is protecting the 1115 waiver in the current federal climate. And so I just, it would make it crystal clear, just because we wouldn't want it to be misread.
We will make it crystal clear.
Thank you.
good luck for the board trying to set minimums for Medicare. That's all. Yeah.
So, all right, so we're still in hospitals. Maximum amounts that hospitals will accept. And then, I think we just put out about the highlighting on this one. Board shall identify factors that would necessitate terminating or modifying the use of reference-based pricing in one or more hospitals, such as a measurable reduction in access to or quality of care. Number 5. I had to change, where the Comprehensive Primary Healthcare Steering Committee lived in statute. Since you took it out of the blueprint, I want to take it out of the blueprint statute, so I moved it. So that's what this is in green here, just to show you.
Thank you.
You reference, the board may, so consistent language from above, I will add Medicare and Medicaid. Consider establishing reference-based pricing for services delivered outside hospital by setting minimum amounts that shall be paid for the purpose of prioritizing access to. So this, Representative McFawn, is kind of a little more detail. Setting minimum amounts that shall be paid for the purpose of prioritizing access to high-quality healthcare services in settings that are appropriate to patients' needs in order to contain costs and improve patient outcomes. So that's why the minimum. Anything else on this section?
Leslie?
Just a reminder, what's 9403?
9403 is the statewide healthcare delivery plan established pursuant to 94. So it comes later in the bill where we.
Okay, I looked down, I just probably glazed over.
Yes,
Sorry.
it's where the statewide
Yeah, yeah.
healthcare delivery plan is.
Thank you.
And I want to remind everyone, because I know this is a very short timeline, but we have the Green Mountain Care Board coming back to us to give us an update in 2026 on their efforts to implement reference-based pricing. And if at that point they come back to us and they say, boy, this is a lot harder than we thought, and we've been working really hard at it, but it's half-baked and we can't get there, we can change the timeline to give them additional time. Supper.
Is the model still in here? They're gonna pick. I thought they were going to, in the original one, there was gonna be they were gonna pick a hospital and,
Global budgets you're talking about?
Yeah, that was.
oh, was it a global budget cycle?
Right. Yep. You have them coming back to us in the reporting saying whether they should move forward with global budgets.
And that's where the model is.
There's no, you mean like a pilot?
Yeah.
There is no pilot.
Yeah.
I think they were gonna begin implementation with non-critical access hospitals for global hospital budgets, but that language is out.
All right, okay. Thank you.
Okay, so section 3A, there are no changes. That was just the adding the definition of hospital network into the hospital budget review subchapter. I think there are no changes in section 4 because most of section 4 came out. This is what the hospitals have to do with respect to hospital budget review. And I told you a bunch of stuff was struck, but so we have the asterisks to say not actually coming out of the law, whatever was in the law in A, but the only change is standardization. Section 5 is budget review. I think the changes here are minimal. I think it's just, so we have considering the statewide healthcare delivery strategic plan, hospital network operations for a hospital that's part of a network, a lot of renumbering, some additional language around salaries and compensation, and different types of employees. Individual hospital budgets, again, we added in consistency with the statewide delivery strategic plan, reflecting reference-based pricing. These are not changes, just reminding you what's in here. Additional provisions for a hospital that's part of a network, meaningful variable payments and incentive plans. And then in E, the one change here, well, two changes, but one you can't see because we took it out, is on this reverse CON concept. I did not include the communities notice to the communities who had decided not to put that in. And this reflects the reduction in number of days to 45 days. It's in the legislation yesterday. All right. That is it for that. Section 6, hospital networks. I think there are no changes. I cleaned up from yesterday. No additional changes. Healthcare contracts, just maintaining that existing language and adding the new language. So I just took out the highlighting. Now we're into the plan and the advisory and steering committees sections. Section 8 is the statewide healthcare delivery strategic plan. I just changed that reference first to where the primary healthcare steering committee will be. And now we do have some changes coming, so let's see what I can tell you. So I incorporated all of the changes that you had agreed to in number 2, took out what had already been struck out with what happened number 3. This is the new number 3 that we put in, and then took out number 4, which was VTQHC's performance metric and accountability measures language, because we went with what was section or subdivision 8. And then number 4 here was number 6 in the old list for anybody who's trying to keep track. We'd switched 6 and 5. So 5 actually stayed 5, but 6 leapfrogged over it and became 4. And then 7, we had taken out and made its own thing, the evaluation framework. Right now, I'm not sure I did. I didn't add that to section 15. No, because I didn't get to section 15 yet. So I still have to add that to section 15. Sorry about that. I don't think that would be in.
Can I ask a question real quick?
Yeah.
Section 9371 of title
Yeah.
18.
Yep.
What is 9371?
Principles for healthcare reform.
Brian, does that, since we moved that to, that the plan, the number 1 on the plan is that it aligns with the principles of healthcare reform. I mean, that sort of gets to your point that you had at the beginning.
Yeah, it's,
That we're prioritizing that.
yeah, that we haven't forgotten.
Yeah, we haven't forgotten.
That Green Mountain Care Board exists because of that. Like that was the whole point, was to get costs under control. So we could provide the healthcare to everyone, like universally. I'm looking at the principles now. So I'm gonna read them while Jen's presenting, because it might.
Don't read them out loud.
No, I'm not gonna do that.
Okay.
No, imagine.
Okay.
It'd be like some kind of art performance.
So I did move it. You'll see it coming up later. I've lost my place. Okay. So I moved the incorporating the evaluation framework. Not sure I fully put it in, but so then number 6 is the old number 8 about accountability and continuous quality improvement. Number 9 is the revised version of, number 7 is the revised number 9. Number 8 is the list of what gets built upon, and does not include the rural healthcare task force report after further conversation. So in number 9, which is identify various things, you had moved what was D to A. So that, and then added in that concept of the exemplars of high quality care to stimulate best practice dissemination. So I just moved it, but it's not new. That's why the including here is highlighted. Number 2 is gaps in access to care. And all of the provisions that were in that. C Opportunities to reduce administrative burdens. I didn't show you everything we took out. Some was old, some was new, but you had simplified this to just opportunities to reduce administrative burdens.
So much better.
Left in the barriers to achieving the goals. Priorities in steps for achieving the goals of the plan. This was from Representative Donahue. Barriers to adequate mental health and substance use disorder treatment services. Again, you took out the rest of the sentence about what that results from. Opportunities, do you?
Can we, under F, can we strike treatment services and just have adequate mental health and substance use disorder services? That would mean that we're including prevention and upstream as well as treatment.
Right.
I think that's smart. It's
Just get rid of treatment.
Yeah.
Yes,
Yeah, just
because then it covers more.
and then
hold on just 1 second. No, that's okay. I just don't want to. No, I totally wasn't. All right.
sorry to do this to you, but on page 18. I missed.
Oh,
the-
wow, we're going back 3 pages.
I know, I'm sorry. Under 2,
Same thing.
yeah, line 5. At the end, including primary mental health services. What are primary mental health services?
They are actually a thing for purposes of health insurance co-pays. Because I know they have to be differentiated into primary and secondary. It didn't seem appropriate to just put mental health services under primary care because some are primary and I think some are not. So that's why but they had been interested in putting, whether from this committee or downstairs, and putting mental health in with primary care. So I'm happy to pull it out as its own separate thing.
So this is only including certain mental health services, not all of them?
Well, under the description of primary care, yes.
Like it doesn't include inpatient.
Right.
But outpatient is primary.
We could certainly take it out of this piece and put it down,
No, I'm just trying to understand what it is.
well, I know the insurers do it because I just reviewed the DFR rule on co-pays for primary and specialty mental health services.
And that's what they say specialty, it's primary, it's the bank, because I wondered what they called the higher level of care, it's specialty, that makes sense.
Yeah,
Just like-
no, it's fine. It's fine, Jen. Thank you. I
That's
just wanted to know what it was.
Okay.
That sounds like language is that language is parity, because isn't that what we'd say in medical, like you have primary care and then you have specialists?
Right.
Yeah, so,
So does that include the DAs? Is that? As a,
I believe that.
They're both.
Services would,
no,
okay, yes.
they're both, depending on the program, I would say it. But I'm not the witness, but like, I would say like, the outpatient unit is primary care, but partial hospitalization is specialty, but.
yeah, that makes sense.
All right, back to page 21.
Okay.
You did lose a few pages here, this is good.
Yes,
I found 7 pages.
yeah, and you'll lose probably a little bit more, although. All right, so we're on page 21. We just made that change. There, enhancements and quality reporting and data collection. So H and then I becomes the last one, and J, we moved the exemplars up to A and took out strengthen Vermont stewarding health system. Then we had the reporting, and you had changed the update to, after much parsing of when legislative bienniums run. It's just confusing, to December 1st, 2029 instead of 2028.
Brian,
Yeah, so there's one word I wanted to add in. It's page 18. So at the beginning of near the beginning of the section. In number 2 on line 4. I want to add universal in front of access, because if you read this section 9371, it says the state of Vermont, the first principle is the state of Vermont must ensure universal access to and it goes on. And so I think it would be in alignment with the existing statute that we just referenced to add universal access that doesn't talk about how we're financing it. So it's not overcommitting us, but it's honoring the existing law and being clear that we want everyone. So without calling it a public good and without going down a road that people are worried about, like saying, you're allowed to have it, like you're allowed to have street lights and snow plows and public parks and stuff, we would just be saying universal access, which is what number 1 says. So it would just be adding universal. It would just be making it in alignment with the statute it's referring to in the previous.
So what you're saying is rather than referring to it, you put it in.
Exactly. Instead of saying,
No, I think you leave the principles, but say identify existing services and promote universal
Oh, yeah.
access across Vermont.
Yeah.
Number 2.
we leave number 1, but we're just adding a word to number 2 to make it more in alignment with number 1 and make it more clear that the plan shall be thinking of it as universal access, not just access,
And we're not saying that they have to provide universal
Yes,
access. We're saying that they're
exactly.
gonna promote it.
Yeah, and then we're not saying how it's financed here either, so we don't go down that road. They're welcome to, if you look later, they can weigh in on that if they want. They have the wiggle room to give additional recommendations.
So this is in addition to what's already.
Yes, it's just adding a word in front of access.
Does anyone else have any thoughts about whether to include that or not?
I'm good with it.
I'm good with it.
Just looked up the definition of universal.
Well, it's in the law already.
It
so-
wasn't easy to get down to another word than universal, so let's do it.
And that would satisfy me as a compromise with the public good thing, because it's a way to kind of imply what I was getting at, using the existing language of the law that we're referring to in the exact part of the bills.
So just remind me what line that goes on,
Line 4.
line 4.
That's how things work around here, haven't you?
I know where we're headed.
It's like, 1 paper cut at a time.
So we'll add universal in front of access.
Just put in the bill, Brian.
Okay?
Put in the bill.
It's coming.
All right. So now we're up to section 9, the Healthcare Delivery Advisory Committee. So a lot of this is just incorporating the changes that we talked about yesterday. You did add one more person, so I have changed from 17 to 18 people on the advisory committee.
I have a suggestion too.
You have added the executive director of the Vermont Program for Quality in Healthcare or designee.
So there needs to be 9 people who come, or
10 people.
10 people. 10
Have a
people
quorum.
need to show up
Have a quorum. Well, for them to take action.
for them to take action. Okay.
Although actually, they're advisory. We didn't even put a quorum. I didn't even put a quorum requirement.
Okay.
for advisory.
Oh,
Okay. So 2 people can show
I
up.
mean, typically that's how they work anyway, but do you want a quorum requirement?
no.
That would be enough. Because the more people we add,
And they don't have
Okay.
binding power, so I don't think we need that level of
Just
accountability.
advising.
Yeah.
Brian,
Yeah, so I'm not saying we need to add this, but I was like, what are we missing? We created a Health Equity Advisory Commission, and I know right now equity, that word is under attack, but if we're not considering including them in this, then I feel like it's a big missing piece, but it may not be that they're on the advisory council or whatever it's called. I'm sorry, there's so many different, what is it called? An advisory committee. They're not on the advisory committee. They may not have to be on the advisory committee. There could be another way that maybe we ask the committee to consult with them, or maybe we ask someone to include them. But if we're not including the formation of the Office of Health Equity and the Health Equity Advisory Commission in this, then we're basically leaving out the government apparatus we created to address those disparities as we're reforming healthcare delivery and finance. And I think that's a big missing piece, but I'm not saying the way to do it is to add them to this gigantic committee, because they have 22 members and it's really hard for them to function with that many members. So I don't want to I'm just putting it out there that was the missing piece. I don't have the solution. I'm open to suggestions. It could be that they consult with someone in here somewhere. It could be that somebody gets appointed who's both, this and that. Like, I don't know. You know, like a,
So if the committee wanted to add something, I think you could certainly require them to consult with some other entities if you'd like, and if there's something you want them to do with that
well,
information.
You're saying the committee should, the Healthcare Delivery Advisory Committee should consult with,
that commission.
Or, you know,
Committee.
seek input, solicit input, or whatever you want to.
Is,
If that's something the committee is interested in doing, I think we can find a place for it.
the
But
committee interested in advancing this?
we don't even have the Office of Racial Equity on here. So we're like missing a piece of something we created to address disparities at a pivotal moment. I think that's like what I'm worried about. And I'm looking at like, how could we do it? Without like remove
they
some,
could consider how to incorporate the recommendations of one of those.
I like this.
Advisory.
can I bounce something back put out there based on what you said? That if there's a way that we say that whatever, there's so many committees, what is this one called again? Is this the delivery?
Yes,
The
delivery.
delivery committee should review the recommendations of the Health Equity Advisory Commission reports or whatever, but then the other side of it should be that the Health Equity Advisory Commission should weigh in on what they suggest too. So I think it should go both, like they should look at what the commission has already done, but then the commission should be weighing in on the plan regularly. That's what I'm getting at. Like maybe, and I don't want to keep another section of the bill where it's changing the law on the Health Equity Advisory Commission necessarily, because I feel like that's where it would be leading if I pushed in that direction. But
I would think, yes.
yeah, but unless it was an easy way to do it, but I don't think there is, and I don't want to
So it sounds to me like you're more looking to add something onto page 22
Right.
on,
That's what I'm hearing, yeah.
yeah,
Let me
that's
look,
what I'm
that might
hearing.
be
Yeah,
correct.
page 22 is just what the Healthcare Delivery Advisory Committee is created to do
What are they to do?
It does mention disparities earlier on
in the plan.
in the
Yeah.
plan as part of the charge.
So if this is something the committee is interested in, I certainly think I can come up with language, but I want to get a sense from the committee if that's. We're interested.
I think we should.
I think we should, and I think that we could even incorporate it into 1 through 5. Something around equity.
Well, my thought would be potentially to have them consider or review or consider the recommendations of the Health Equity Advisory Commission and determine how best to incorporate them into healthcare delivery as appropriate.
Yeah, is there a way to, oh, yeah, and I was gonna say something else just for you to like digest and see what you is like seek their consultation or seek their advice on the plan before it's done. You know what I'm saying? So look at what the work that the commission did, but then before this is done, check in with the commission to see what they think of it before it's like finished, if that makes sense, however you want to say it.
That would go in the plan section if that's something that people wanted.
I would prefer putting it into I don't want to add anything more to the plan.
I don't think it would go into the, I mean, if you were going to do it, it would be in the plan process. I think the Healthcare Delivery Advisory Committee is.
I would just like the Healthcare Advisory Committee to consider and seek input.
Oh, we
So-
I'm on the committee.
Because there's 100,000 people
No,
on
I
it.
know, but if it's that important,
I think it is, but I'm not gonna like fight
I'm not
over
opposed
it.
to putting them on the committee. Is that,
Oh, okay, that would help. It would just help it.
okay. Then let's just add them to the committee.
Instead of having the committee consider their
I would say both.
recommendations
they're
and
on the committee.
If they're on their committee,
They're gonna be involved in the whole thing.
Okay, I think that's fine.
so just take this out and
a representative from,
I mean, you're addressing the concern. I didn't have an exact solution. It's just that we're missing something. Too often we create things and then we don't follow what they say, or we don't follow through on it, and I didn't want that. Or add another section, we can expand the power of the health
18.
committee advice.
go to 19.
Gee, I'm just teasing, honey.
I like E.
Wait, but they're going in the,
Let's just put them
putting them on the advisory.
on the advisory committee and not worry about language.
So is that an R?
I'm feeling like they need to go. I might put them up
Yeah.
further.
So. Madam Chair,
Yeah. Okay.
to Reynolds' point, the budget moves the health equity office, GOA to Department of Health. Just one more.
But this is somebody from the Health Equity Advisory,
No, I'm just telling you where they moved to, because they're not
Right,
part of AHS.
not the office,
Just-
right? Is that,
That is right. You're also, what you're saying is true. Like they actually are finally creating an Office of Health Equity. It's taken a few years. Which I think that, then if we have a member from the commission here, they can make sure that that is being incorporated into this plan and we're not just having like the siloing happen.
right?
Yeah. So I'm satisfied with the solution though.
Is
Okay.
anybody not satisfied with that?
Thank you. Thanks for the straw poll. Are you not satisfied? You raised. your
I'm
hand.
satisfied.
Okay, good.
I'm-
We're satisfied. We're
recommend.
adding them to the plan. Woody?
A question regarding time frame. How long will this committee exist? Is there a time limit?
Not in the language.
We could say until the June.
But they are not getting paid.
Well,
And then it
or
goes back.
until reference-based pricing is. I mean, it eventually will go away, I would imagine.
I'm assuming since they're being created to advise the statewide plan, that they would probably
Yeah.
meet a few times.
Yeah.
Right, but they do more than that. They're evaluating and monitoring the performance of the healthcare system and its
Yeah.
impact. I mean, that's sort of an ongoing.
And once the plan has been come up with, and then we start implementing the plan, I would imagine that they would meet less frequently to monitor how things are going.
In all honesty, this does create a new structure of government in that.
We're not creating a structure of government, we're creating some oversight on,
On structures of government, okay.
yes.
Okay, so we will be at 19.
Because there's not an existing commission or committee with these names yet, right? I was trying to look in the law and we're creating two new
We're
committees.
creating two new committees.
We should cut like 5 in the process, so, satisfies those who don't want large government. But I won't go there right now.
So now we're at section 9A, which is the Comprehensive Primary Healthcare Steering Committee. And this I've put into Title 18, near the beginning of Chapter 221. There's a lot of stuff going into that area. There's some empty numbers that have been empty since Act 48 time, so I'm reusing some numbers. See, there's efficiency. We're reusing some existing.
Yes.
So this is the Comprehensive Healthcare, Primary Healthcare Steering Committee. Consultation after the committee. These should be from these chairs are at the UVM Lerner College of Medicine, not at the medical center, so made those corrections. We changed the people who, the person from an independent practice and from an FQHC to be a primary care clinician. There's some flexibility in what the provider type is, as long as they're in primary care. Fix this wrong reference. Steering committee is receiving administrative and technical assistance from the Agency of Human Services, but I wasn't sure because the executive director of the blueprint is on it, if you still want that person to call the first meeting and then they can select their chair. Seems like it was important to have somebody, and I thought, so I didn't change the executive director of the blueprint as who calls the first meeting.
Yeah.
But
And
then underneath, and the next provision, they will select a chair from among their members at the first meeting.
let's keep the executive director.
Okay. Like a good identifiable individual. All right, section 10 is we made some changes, a bunch of changes, and made this an integration of healthcare data.
Just skip it. We moved down from 9A. Can I just, I was reading it again to try to be, so forgive me for not being quicker. I'm assuming people would not be open at this point to asking them on page 27. It says develop proposals for sustainable payment models for primary care. That asking them to explore universal primary care.
I don't want to tell them, I do not want to tell them what they're to come up with. I want them to explore proposals.
As long as we already tell them that it has to be in line with all these other principles. And so they're not going to come back and say, here, a sustainable model is, something that not everyone can access. Because it's saying they have to enhance access. So I can trust, I can let it go. I had a feeling people were going to say this. Looking at my notes before we move on, if there was anything else there, so just give me a second. I don't think there was. Yeah, it was just that piece that I was suggesting that perhaps they look at the incremental implementation of Act 48, starting with primary care, but it sounds like it's too much to ask. And they certainly could, if you're out there and you end up on this committee,
Might be.
you're welcome to look at that, because we're saying, however, whatever you want to come to us with, you can. So because it's so open-ended, I can support that. So I can let it go. I'll just lobby them after and go to their public comments and try to make my case.
Brian, on paragraph 9, item 18 or line 18, shouldn't we put something in there?
Where do you see that?
Line 18.
Yes. Yeah. We could.
He's fading
No, he's not.
I don't think you increase universal access. They're either
Oh, you're right, because
increase on your way to
Have it.
You're not
Yeah.
helping.
Page
Just
28.
trying to help.
Okay, section 10 is the integration of healthcare data and report. We talked about that yesterday. And I incorporated all the changes. The only additional language here that I put at the end is that the agency shall not begin implementation of an integrated statewide system of clinical and claims data unless and until directed to do so by legislation enacted by the General Assembly.
I see hands.
Eli?
Eli Haggett, Agency of Human Services. So AHS, Premium Care Board, and the Office of the Healthcare Advocate had suggested language for the section that would include a not beginning implementation without a vote of at least 51% of the HIE steering committee, who we believe are the experts, and I think pretty much every organization in the room has a seat at that committee. And so this sort of it seems redundant in that the people you would listen to about whether this should happen is going to be the HIE steering.
So I think that when AHS comes back to us on January 15th, 26 with the recommendations, then they would certainly indicate that, 51% of the HIE steering committee is enthusiastic to proceed with this, and we want to proceed. I think that's all we're asking, is that you come to us before you proceed. And a recommendation such as what was in the consensus language is a great thing to give us when you come back to us. So I don't think we're precluding that. I think it was the opinion of the majority of members of this committee that we find out the value of something before we start investing in it. And all we really want is you to come back and tell us, wow, we found out that this is a really worthy investment. And I would imagine that we would move forward with it at that point. Does that make sense?
I
Okay.
can hear that.
Okay.
Another option would just be to put a date in that they shall not begin implementation until, or prior to July 1st, 2026, and then you get to decide when they come back with their report in January. You want to tell them not to do it or not to do it.
I think this language is good. I mean, they're gonna come back to us January 15th or 26th.
Right.
Anyways,
You would just have to.
The feasibility.
You would just have to legislate it or repeal this language if you wanted to allow it to go forward.
yeah, no,
Sheila, do you envision that this would cost money to do if you were to do it?
It depends on what a feasibility study would.
I'm saying like the implementation of an integrated statewide system of clinical and claims data, would that cost money if we did not have this language? Great, let's do it. Would you have to be coming to the legislature for an appropriation to do it anyway?
To do that data linkage,
Yes. See where I'm going with this?
I am not certain.
So the administration has to get spending authority to do things that it wants to do. This sort of could fall into that whole thing too, like you can't do it unless we give you the spending authority to do it. So this is sort of along the lines of that as well. So to the extent that the administration says, great, we want to do this, it includes it as part of a budget ask, then you're seeking authority, spending authority to do it. So my question is, if this requires money to do it, then technically you would be asking for permission anyway with the spending authority in the budget.
I'm not sure if it would be general fund, if it would be HAT.
Doesn't
fund.
matter.
Okay.
You still need spending authority. So anyway, that's an avenue. My point is trying to help find compromise here. So. you can find that out.
we, in your compromise, which I'm liking where you're going, and I know exactly what you're referring to, would it be the agency, shall not be, or
I think this
something
language
about an
says what
appropriation?
It's talking about, right? Does this language?
I mean, the agency shall seek authorization to the budget process or something. I don't know, just trying to.
I think this can work for
Yeah,
that.
Jen thinks it's great, that's fine. I'm just trying to get to the point.
Yeah,
If it needed appropriation, you'd still have to come to the legislature to do it
Yeah,
anyway.
You can't start it. Okay, let's try to,
It's about the report, but
oh, okay,
yeah. That, it, although it does say, I read ahead, I'm sorry, I'm going backwards. Okay, although it does say in, on page 29, line 8, number 4, appropriate privacy and security safeguards for an integrated statewide system of clinical and claims data. I don't see anywhere in the report an assessment of the risks of such a system.
well, there's advantages and disadvantages.
Yeah, so in a very general sense, it could fit there, but that's just something I noticed. Because we had heard in the testimony when I was suggesting a universal medical record system, people saying, well, what if they hack into that? Well, what if they hack into this giant claims and clinical data? So I mean that, and so it says appropriate safeguards, but it doesn't really talk about, and it doesn't say that they have to tell us what the actual risks are. That makes sense. So they could say, oh, it's encrypted in this, that, and the other, but they don't have to say, oh, every day China has AI attacking our healthcare medical record systems,
I'm
which.
not sure I'm going to be able to tell you the actual.
Hey, Topper, you're in
No,
charge.
don't you, oh, I'm sorry.
Yeah.
Go ahead.
I can assure you that would be a discussion within the HIE steering committee.
Happy saying it's.
How does the committee feel about the sentence that said the agency shall explain the advantages and disadvantages?
Works for me.
yeah,
Works for me.
Good.
Where is that?
It's in
18.
line 7, line 18. Okay, Jen.
Okay.
There's
Section,
no questions or anything about that now?
No, I'm gonna
Okay.
take your word for it that you will consider that. And that and we're hearing it's covered by the language, so.
Not just myself, but again, all the advocates in the room.
Yeah, like you, like Ustedes, like all of you, yes, you. Thank you.
All right, let's go.
that's everything, all y'all.
All y'all's word, I'm gonna hold all y'all to it.
All right,
Thank you,
section.
Jen. Let's go.
Section 11 is the language we looked at yesterday that would limit the board's ability to share materials it receives through subpoena or notice to produce with just to the Agency of Human Services and DFR as appropriate to their work. section, the next group is what I called healthcare reforms addressing exigent needs. And that what was regional and is now non-regional, spending reductions. So this has the Agency of Human Services facilitating collaboration and coordination among healthcare providers in order to identify opportunities to increase efficiency, improve the quality of healthcare services. That I added reduced spending on prescription drugs and increase access to essential services. And then while reducing hospital spending, so not overall healthcare costs in Vermont's healthcare system, but hospital spending per hospital fiscal year by not less than 5%. We're expecting, yeah.
Sorry.
You know, that's good.
Takes the village.
Thank you, Devin Green from the Vermont Association of Hospitals and Health Systems, and I'm just gonna pull a little bit of a Mike Fisher here and say that I feel compelled to say, you know, we know that the committee's going in this direction. 5% of reducing 5% of hospital spending in 1 year is a very lofty goal. It's about $200 million. Already hospitals are making significant reductions to meet this year's budgets because a lot of their labor is at 6% and the budgets had to come in at 3.4%. The overwhelming report, doing everything in that report saves $400 million over 5 years. We're doing $200 million in 1 year. So this is going to be significant. And I just want folks to understand and know that from the hospitals.
If they don't meet that goal.
There is no enforcement in this bill.
They'll be shamed by the press most likely.
Right.
Seems to be the most common thing that happens.
Brian, go ahead.
So once again, this is just a thought. It's not a suggestion. Maybe general come up with a phrase based on this that the committee likes, but I see us asking them to identify increasing efficiency, improving quality, reducing spending, increasing access. What about this concept of reinvesting? Like reinvest, so like instead of it being so much about cutting, what if like we ask them to consider ways to reinvest existing spending?
So I think at least in the short term, the idea is to reduce spending in order to pull them to reduce the increase in health insurance premiums.
So people can more.
Yeah, I'm not saying not to do that, but like also to consider reinvestment, because they might come back and say, but we were able to reduce the spending, but we didn't do it by cutting, we did it by moving money around.
Transformation work is really more reinvesting. This is.
So you're saying there's another part of the bill that's more the reinvestment?
Yeah, I mean, I think Act 167 and the work that's being done there is really looking more at reinvesting, changing the way care is delivered, which might be, yes, which I think is more in line with what you're talking about. I think this is really specifically looking at pulling money out of the system.
Like, this is the part where we are creating pressure on the higher level of care to reduce spending so that we free up money to invest in the, I don't want to call it lower level of care.
I think that's the transformation work.
Okay. Well, so what part of the bill does it refer to reinvestment or does it not?
I don't think this one does, and I'm not sure even Act 167 uses that term, but I think the way things are described, I mean, we talk about consolidation and changing care delivery is that concept of reinvestment or taking money that is spent in one way and spending it in a different way is incorporated into that. But I don't know that literally the phrase for the word reinvestment.
I'd like to like just pause on discussing that till we get to the next section, because I think it addresses it more. So to your point you just said, so I don't want to we can move on and then we can come back to it, because then I looked ahead and I'm like, oh, it actually might make more sense to talk about this in the next one.
Okay.
Now that you've helped me see that this part is about cutting or lowering and the next part's about so thank you.
Yeah, the next part.
I see it
is
now, yeah.
What's going on with transformation.
Yeah.
Okay, so then I didn't make any additional changes in I do want to check in with Devin for a second on the state action immunity and make sure that feels comfortable to you. Okay, great. Evan has been very helpful in, and I think we've been sort of collaborating and getting up to speed on some of the antitrust language to make sure we're using appropriate terms.
Mike, did you?
What is this? Doing a Mike Fisher. I will also do a Mike Fisher. I am Mike Fisher. Health advocate. I didn't speak up about this yesterday when this language was added. And I guess I'll just say I'm confused about, we have the agency who's tasked with this, we hired a contractor, we're spending a lot of money, who's tasked with this. And the hospitals say they need a space to be able to talk without anybody in the room. And I don't know how that adds, maybe I just want to go on the record as expressing a concern about how that adds to the overall coordination and coordination of this whole effort. And I would think at least the agency who's supervising this effort should be in the room for those discussions.
Lori, I'm gonna let you.
So I, in a way, share those concerns, and I believe that we need to ensure, and I've said this before, so I'm going to be brutally blunt. I don't think the transformation work is going fast enough with what AHS is doing. And so I do want the hospitals to be able to do the work that they need to do and have committed to do in order to ensure they are looking at every possible way to.
Can I just throw in that I remember when we did that testimony, the joint testimony that we did with Senate Health and Welfare in particular, was one of the hospital chief executives, and I can't remember which one, but he talked about the frustration that he was reaching out to other hospitals to try to coordinate care. And some he couldn't even get calls back from. And he didn't feel as though there was a space. And I just remember popping into my mind, which was, why is AHS not taking the reins and saying, here we need to be working together? And if this language gets us to that, then, and if not, what language gets us to that? Because that's what we're trying to do. Somebody to coordinate. So it's not just 14 aimless hospitals trying to like figure it out on their own.
Don't get me wrong, I'm all in favor of coordination so that we can effectively do this. I just on a very high level, antitrust is a consumer protection. You know, colluding, you know, allowing private entities to collude in order to, you know, cut up the pie in ways that they want is the reason that we have antitrust laws. And I understand that this is framed as in an effort to reduce spending, and so that does turn it on its head a little bit for me, but I just wanted to go on the record as having a real concern about this section.
Diane, did you want to weigh in, and then Leslie?
Thank you, Madam Chair. Diane Lambert, Green Mountain Care Board. We didn't have an official piece of this, but we did, the Green Mountain Care Board. Some members expressed some concern about this as well yesterday, and we would echo the comments. I won't try to hold my vision, but I'll do so.
Leslie, and then I think we're going to take a break.
Can we, sorry, can we read can you just remind them that we have a section, second piece where they are reporting back their plans to AHS?
That's my question.
Yes.
Yeah.
Yes,
So let me just,
so this allows that, I'm sorry, do you want to ask?
If I may, but it's just expanding on this question. That was my question for you. Does this language, the agency shall review each proposed, how does that address the concerns of antitrust? Does it come out of that secret room then in a way that we're
That,
less uncomfortable with
that
it.
nothing comes out without approval.
Yeah,
Right.
Okay.
And that's important for state action immunity is that it's not the regulated or, not, it's not the industry making the final decision about what changes happen. It's the state making the final decisions about what changes happen.
so I was wondering how you felt about
So
it.
we why don't we get to that and then we can address
Okay.
that?
So the language says, in order to encourage cooperation and candor in developing rapid responses to the urgent financial pressures facing the healthcare system, the representatives of hospitals and other healthcare providers may meet outside the presence of the agency to develop proposals for spending reductions pursuant to this section, provided, however, that in order to ensure the supervision necessary for the collaborative process to be afforded state action immunity under applicable federal and state antitrust laws, the agency shall review each proposed spending reduction to evaluate its feasibility, its consistency with the state's healthcare reform goals, its alignment with the Act 167 goals, and its ability to contribute toward meaningful cost reductions in hospital fiscal year 2026 without reducing access to essential services. The agency shall modify to the extent practicable or reject any proposal that fails to meet the criteria set forth in subdivision 1. The agency may approve any proposal, but does not have to. It gives the discretion to the agency, may approve any proposal that it determines meets the criteria set forth in subdivision 1, and may also work together with one or more hospitals to develop additional proposals that meet those criteria. And then the agency will report on the proposed reductions it has approved, including applicable timing and appropriate accountability measures to HROC and the Joint Fiscal Committee, and then continue reporting.
Woody, I see a question in your eyes.
I do have a question or actually a comment. And it may not pertain to what we were just saying, but it has to do with the 5% reduction in hospital costs. And I get that we're dealing with hospitals, but are there other organizations within our healthcare system that we should also be looking at in reducing costs that will eventually help the system? Rather than just having it all on the backs of our hospitals.
So 60% of our healthcare is administered in hospitals.
And the hospitals.
And the other 40%?
I mean, I think the data has shown that the hospitals is where there is the need for reorganization. I'd be more open to a compromise on the percentage than I would be going into other healthcare settings besides hospital. That's something we can talk about after we take a break.
And what would the proposal be for other healthcare settings?
I don't know. I'm just raising that top.
To control costs in other
And
settings.
in other sections, yeah.
Doesn't the bill suggest that that they might do that by setting the prices or the fees or whatever for all healthcare services at some point?
Reference-based pricing.
Yeah.
Yes, that,
Yeah, so we are doing it with, yeah.
right, but not in this. Not in
Yeah,
this section, although this section does allow the hospitals to meet with other healthcare providers, which might be looking at ways to transition care more into the community.
or like maybe they allow providers to buy into their medical record system and that reduces their cost of the medical record system. And then we can we don't have to deal with an actually. So I think there's different ways they could be creative and do that, but I don't, does the language say consider partnership in the community or anything like that to lower costs or work with other parts of the system to try to?
It requires the agency to facilitate collaboration and coordination among healthcare providers.
Okay, there we go.
Although the cuts themselves are specific, required cuts are specific to hospitals,
But they might be able to make the cuts through collaboration and that, but with this language, that's good.
that's right. I think that's the idea behind the language.
Okay,
Okay.
move on. How many minutes do you think we have to go?
So I will say it would be great to finish getting through this because I'm gonna need to be elsewhere for a bit fairly soon.
Okay.
Where are we at again?
So we're on page 33.
Wrong thing,
Section
thanks.
11B is tasking the Agency of Human Services with identifying specific outcome measures for determining whether, when, and to what extent each of the goals stated in Act 167 have been met. We did not make changes to this, and then it has a some reporting from the Agency of Human Services, the outcome measure, how the agency will determine its progress in accomplishing them and achieving the transformation goals. The impact that each transformation decision is having, how they are tracking and coordinating transformation efforts of individual hospitals to make sure they are complementary. The amount of state and federal funds spent on Act 167 transformation efforts to date, and the amount of unspent Act 167 funds, and then monthly reporting. So, and I don't believe we made changes.
Brian, if your question is less than 20 seconds.
I've reviewed Act 167 a few times while we're sitting here, and I don't see an explicit list of goals identified. So I'm curious, you don't have to answer it now, but where did we get this list of goals from? Because they're so like.
So this was in the agency, I believe this is from Act 167.
From the act or from the
Yes.
report? I don't see it though.
So this came from, the presentation that was given at our joint hearing a week or two ago from AHS.
But when I look back at the.
I'm looking at the list of goals, how they were extracted from.